Good morning, everyone. My name is Aidana. I'm a graduate student here. I'm also from SPI Optica student chapter. And it's my pleasure to introduce today's keynote speaker, Laura Marcu. She's a professor of biomedical engineering department and the director of National Center for Interventional Biophotonics Technologies at University of California, Davis. She's best known for her research in fluorescent lifetime-based instrumentation and the imaging systems to study molecular, morphologic, and the metabolic changes in living systems. She's also a fellow of numerous professional societies, to name few: National Academy of Inventors, SPIE, and Biomedical Engineering Society. Thank you so much for coming, and the stage is yours.
Good morning, everyone, and thank you for the kind invitation to speak here today. It's my first time attending this meeting. It's actually, I see a lot of microscopy and also image analysis, dealing with data. I'm not going to talk too much about microscopy today, but rather I'm going to talk about fluorescence lifetime imaging, more of a mesoscopic scale rather than microscopic scale, with the idea of translating optical techniques into a clinical environment. Ideally, yes, is to go to microscopic scale. However, will take some effort to get to that stage. But however, mesoscopy can still help on diagnosis and characterizing diseases. So if I show you these two pictures, which are taken about a century apart, you probably can notice there is no dramatic change in the surgical environment. And despite of numerous technological advances over the past century, is still the surgeon's eye and the surgeon's brain that helps with diagnosis at the time of the procedure, navigating inside the patient and making a decision. And clearly, there is a need for new technologies and new approaches that at the time of the procedure can help with, for example, visualizing better the tumor ages, so we can increase the chances of complete removal. So to put this in a perspective, when surgeon enters the operating room, typically they have available the radiological appearance coming from MRI, PET-CT, classical medical imaging approaches, patient history, physiological parameters. However, in multiple clinical scenarios, more detailed information about chemical, morphological, or functional features of relevant tissues will be helpful, not only for making a diagnosis, but most importantly, to choose the optimal treatment. So if this information can be also provided in real time, the real time means microseconds, seconds, minute, then that can lead to personalized intervention, optimized outcome. So here I see the opportunity of many optical techniques that are currently emerging on filling this gap and actually provide this real-time feedback in conjunction with other methodologies that I'm going to briefly touch upon later. So today I'm going to talk about one of these techniques, which is fluorescence lifetime and imaging, and in particular fluorescence lifetime. Some probably in the audience know that fluorescence imaging over the past decade or so has emerged as a promising method for guided interventions. And there are actually clinical or commercial instruments for this to address this need. So fluorescence has clear advantages in a sense that can provide real-time guidance. These systems are cost-effective or efficient, and importantly, they allow for flexible implementation that can be used as open systems, that can be coupled with endoscopic systems, and also it can guide the human eye beyond the natural limitations by leveraging either endogenous or label-free contrast or exogenous molecular contrast. So despite all this, clinical adoption of these techniques remains rather limited. And perhaps one of the reasons that this is the case is that most of these instruments, I would say probably in terms of commercial systems, probably nearly 100%, are based on intensity and spectral measurements. So these measurements are more qualitative rather than quantitative, and are subject to either imaging distance, non-uniform illumination, tissue optical properties, and that would require practically, in order to apply them or use them in a clinical environment, complex calibration protocols. So provided that you can actually measure the fluorescence lifetime or the time these molecules will emit following excitation, then you can actually overcome the limitations of the intensity-based systems, and also you can enhance the molecular specificity. However, these systems are more complex, require long data acquisition time, and they did find numerous applications, and actually the significance of and importance of using lifetime measurements has clearly demonstrated on benchtop experiments using benchtop flip systems in cell culture, spheroid, small animals, and some of this advanced research is actually happening right here at Madison. So studies have demonstrated the use of lifetime and the importance in metabolic imaging, studying drug efficacy, in neurobiology, and you name it. So there are many, many applications using film systems on a benchtop. However, the clinical utility of fluorescence lifetime imaging remains largely unexplored. So this is what we are trying to do, or we have tried to do for several years, is to find solutions to translate these instruments from a benchtop to a clinical environment. And that requires a new level of addressing a new level of problems, which means real-time data. Surgeons are impatient. They really want to have data in real time. You want to have systems that can adapt. You can collect data regardless of the surface that's coming from, regardless if you have blood or other fluids. So have a way to adjust the sensitivity of your detector in order to detect data regardless of the conditions. You have to be safe in the sense that you cannot deliver too much light or photons because, especially if you work in UV, you may actually damage the cells. And also, in order to be adapted, these techniques have to provide an image, a way to augment this information so they can make decisions based on what they see in front of them. So there are different type of methods of developing film instruments. The most common is TCSPC, or time-correlated single photon counting. I just want to, I'm not going to go in detail, but just to emphasize that the technique that we adopted is based on pulse sampling, which means that you can record the whole fluorescence transient using an oscilloscope or fast digitizer in response to one excitation pulse. So this is an example of how this pulse sampling approach, multispectral, was initially implemented, and some of the results I'm going to present today are based on this instrument. So practically you use UV light, pulse, some nanosecond, delivered to a fiber, which excites the tissue. Fluorescence is collected through the same fiber optic, spectrally resolved in multiple spectra, in this case, 4 spectral channels, and time multiplex in one detector, and then digitized. And as a result, in response to one excitation pulse, now we can record simultaneously 4 decays for each spectral channel, which can be tailored to different fluorophores of interest. For example, you can have collagen or matrix proteins in one channel where they have a peak emission. You can have an ADH or FAT, which are the metabolic cofactors involved in cellular metabolism, or porphyrins. So practically each point measurement will provide you with a range of parameters that allows you to characterize the biological system at that particular location. And this has happened very fast, in less than a microsecond per point. And also importantly, for a surgical environment, this is not affected by the room light. So you can do these measurements in real conditions. The methods that we adapted, for those of you who are familiar with fluorescence lifetime imaging, we are not using a multi-exponential approximation. It's hard to estimate how many components or fluorophores will be in tissue. And as a result, we choose to use a non-parametric approach, which is called Laguerre expansion of kernels. We expand the decay on a Laguerre basis of function. And this also provides us to these coefficients of Laguerre expansion that can allow, can be included in characterizing the fluorescence decay. So this is what we're going to see when I'm going to talk about classification. We use all these parameters, but for simplicity, I'm only going to show average lifetime. So then, as I mentioned earlier, you want to visualize this information. So provided that we can now inject the naming beam through the same fiber optic that used to excite and collect fluorescence, and then use the camera, which can be a new camera or big cameras which are already in operating room from endoscope or from a robot, you can actually segment that naming beam, and then you can process the information and then augment the fluorescence lifetime at the location where you took the measurement. So that provides real-time visualization of this fluorescence lifetime, and you can change the wavelength band as well dynamically, so you can look practically in real time of different set of parameters and or visualize them. So that can be done at video stream and also allows you to track the tissue exposure. So here are two of the systems that we currently use in the operating room. What you see here, generation 1, is the one that I just presented earlier with these delay fibers. More recently, we replaced that with the single with APDs or avalanche photodiodes for each spectral channel. So we also have developed in-house a variety of fiber optic probes, which are very simple, that allows us to couple our instrument with different other instruments or use them in different clinical scenarios. And as you can see, these probes can be sterilized, and also they are very thin, we use fibers around 200 to 400 micrometers coarse, so can be integrated in endoscopy and can be also used in different other conditions. So with that, I would like to discuss some of the applications. I will not have time to talk about all of them going on in the lab currently, but I'll focus more on two of them, which are related to image-guided surgery, which is head and neck cancer in the context of transoral robotic surgery, and also image-guided neurosurgery. And I'll have time a little bit. I'm going to talk about how we can use the same technique in a context of intravascular applications to look at atherosclerosis. So I'll start with head and neck cancer. And the surgical goal in this case is to remove the tumor en bloc plus a safety margin. which by standard of care is about 3 to 5 millimeters. So the idea is to minimize, given some of these tumors are placed in functional areas, you want to minimize the amount of normal tissue that is removed in order to preserve function. So there are two situations which are important. One is to define before you start cutting, what is the surgical margins of the epithelial surface. The second is to define, to actually remove everything and block and not cut through the tumor, so you don't leave positive margins on a deep, in a surgical cavity. So when it comes to robotic surgery, which typically applies to oropharynx area, where it's hard to access the tumors, then you also lose tactile feedback, which also the surgeon uses in order to define these borders. So having a way to sense the characteristic of the tissue is very important. So there are 3 clinical scenarios we have been looking on using or applying this technique. One is, can we actually better delineate, how we can delineate the surgical margin of the epithelial surface? Second is, which is very important, is the residual cancer in the resection cavity, because that, if it's left there, leads to spread to the lymph nodes. And there is another scenario, which a subset of these patients who have what is called carcinoma of unknown primary origin, or occult primary, which are tumors, they know that the tumor is present because it's already spread to the lymph node, but they don't know where the primary tumor is, where it is located. And they are typically kind of this fishing expedition when they start the surgery to identify where the primary tumor is. So these are the 3 things that we have explored in a context of robotic surgery. So we've been working with Intuitive Surgical on adapting or coupling our instrumentation to the Da Vinci surgical robot. And we use different platforms. And one is this SI platform that allows you to integrate the fiber optic from one of their surgical or introducer. And more recently, it's an agnostic approach where you can use actually a forceps to pick up the fiber probe and to scan. How many of you are familiar with robotic surgery? Is anyone here? Few people, yes, great. So practically, for those of you who are not familiar with this approach, the surgeon will sit at the console, and from there can see the surgical field of view with a camera, which is in the mouth of the patient in this case. And also, it can use this kind of joysticks to control different instruments in order to perform the surgery. So what we see here is that you see the surgeon on the left, the robot on the right, and all those instruments are in the mouth of the patient. And then you actually surgeon can control now the fiber optic remotely from the console, and the video stream we use the camera of the robot to segment the aiming beam, so this allows with the visualization. The video stream from the vision tower goes to our film instrument. This is where the augmentation takes place, and the augmented video goes back to the surgeon or can be also visualized in the operating room. So this is a demonstration of this concept. You can see here the Maryland forceps. See, grab the fiber optic. This is a single port. And here is the augmentation in real time of the average lifetime in one of the spectral channels on a surgical field of view. So this is actually a real-time augmentation on one of these parameters. Idea is not to augment just average lifetime, but rather to use parameters, the classifier, probabilistic classifier, augment that on a surgical field of view. That is currently done offline. We are developing the classifier based on the data from multiple patients, but this is what we aim to actually augment the probabilistic classifier at the time of the procedure. So there are, to get there, this is practically multi-phased and multi-step process. May look simple, but there are many, many details you have to take into account. One of them is to establish the ground truth, which still remains histopathology. So this means that you have to take this after the tumor is resected, you have to, we actually investigate also ex vivo, and then will be processed, Bradloft, processed by histopathology. So to the best we can, the idea is to map the diagnosis of the based on pathology with each pixel that go back in vivo. So we work on some of these processes, some of this is reported, they're working on new methods as we speak. The other aspect is how you process this data, again, has to be real time, how you classify once you develop this classifier, to develop different methods for classification, and also to visualize. So this means when it comes to visualization, you have to do segmentation of the aiming beam. You want to also segment the instruments in order to be able to augment. You have to correct for the motion. So there are many things that has to happen in parallel in order to get this in real time. So this means it's a lot of computational work that has to be implemented in order to make this work. So here I'm going to just present you some of the earlier approach to correct for motion. This is a block matching approach. So if you see, if you augment, let me see if this works. So if you don't correct for motion, what you augment doesn't necessarily correspond to the location. You really have to have a way of correcting for that, so you can actually augment in real time the exact location where you took the measurement. So that involves also AI, different methods that we are currently been working in the past, but we have new approaches right now. Hopefully next time I'll be able to present this new methodology that allows us to do parallel segmentation of the aiming beam, motion correction, and visualization, and that can be done in a matter of less than a second. So that's, I hope to present next time. But right now I want to show you some of the current results that we reported. For this slide, you see two of the scenarios where it's practically, again, delineating the tumor on the epithelial surface and also looking at the margins. In the left, these are results from 100 patients where we used this probability map of cancer using, taking into account the location of the tumor. The complexity in oral cancer is that the tumor is located in different areas. Normal of a tongue or a superior tongue versus the base of tongue is very different. Or tonsil, so practically have to take into account the anatomical location as well. So taking into account the anatomical location, using this 1D CNN approach and optimal transport near subspaces classification, we're able actually to improve a previous classifier that we reported and show that we can have accuracy over 90% on detecting these tumors on the epithelial surface. What you see now on the right, which is the most challenging situation, imagine that this surface is not clean any longer. You have cautery, you have blood, you have other fluids. It's a whole mess in that cavity. So how can you find tumor if there's any residual tumor left? Also keep in mind that if the surgery is done properly, and the surgeons are good on doing that, you don't have too many cases where you have positive surgical margin in a cavity. So they are good on removing as much as possible if the anatomical location permits. So, however, we did have on 22 patients that we involved in this study, 3 that display a positive surgical margin. And in this case, we apply an algorithm which focus on anomaly detection in order to see if we can detect this tumor in a surgical cavity. So we were able to get accuracy over 70%, keeping my sound low. However, the clinical in a regular clinical situation, this is 50-50%. The surgeons have no idea if that tumor is present or not, so sometimes they miss it. It's a 50% miss of these tumors. They only can find it later on based on the histopathology, frozen section, or even days later when these tumors are processed by histopathology. So the idea is practically, the challenge is that we don't have too many cases in order, it's an unbalanced data set in order to detect these positive margins in the surgical cavity. So here, the idea would be practically what you can see in this video to identify this tumors, which in this case will be considered anomaly in that cavity. So, and the third case, which I mentioned earlier, is about this occult primary or unknown primary origin. In this case, we use a classifier, which was developed from 50 other patients to see, can we actually detect in some of these patients, or has 6 patients with a known primary, tumor of a known primary origin. And in these 6 patients, 3 of them actually we are able to scan areas. Again, it's an educated guess of the surgeon where to scan. We found that the areas which were picked up by or sensed by our technique has a high accuracy in terms of detecting these tumors. Keep in mind, this is a completely independent data set. Everything was trained on 50 other patients, which different patients than the one involved in the study. And the areas where was no tumor, as you can see, was also identified as being benign, which is reflected on this very high specificity. So we study all these scenarios, and as I mentioned earlier, I don't think we can consider optical techniques in isolation or whatever is provided by these optical techniques at the time of the procedure. I think we have to take into account more than that, which is preoperative imaging, again, patient history, everything. So in this pilot study here, I want to show the very beginning, where we want to see if we combine radiomics, which is data that comes from, in this case, CT data, parameters from primary cancer with FLIM parameters, which are obtained during surgery. So it's preoperative versus intraoperative, to see if we can predict the spread of tumor to the lymph node. So this was a surrogate to see if we can study based on this parameter, how invasive are these tumors. And this was just reported, published recently on this diagnostics journal. As you can see that based on radiomics alone, you have about 0.58 accuracy. Based on FLIM alone is 0.72. Combining the two, you increase the accuracy. So we are continuing to add more patients to this study, and also to include a PET data as well, in order to see how we can use this heterogeneous data in order to predict spread. So in summary, we're successful on integrating film system with the Da Vinci surgical platform. We're starting to develop, this is still an ongoing work, different methods for labeling in order to better establish the ground truth. Also, we started to demonstrate the diagnostic values of these parameters and develop these classification methods, probabilistic classifiers. And also, we are looking now on how we can use heterogeneous data from heterogeneous sources in order to predict spread, but also to diagnose. So I'm not sure how much time I have left right now. Oh, great. Yeah, thanks. With that, I'm going to switch gears now to another application, which is the use of this technique in the context of neurosurgical procedures. And here, the surgical goal is, again, similar to head and neck, is to remove all the tumor. This is even more critical in order to not remove healthy tissue from the brain. This is not possible, it's not allowed because you can impair functions. And however, the approach for removing the tumor in brain is very different than head and neck. This is a piecemeal approach where they start from the core of the tumor toward the edges. These tumors are infiltrated in different fingers, and they would they know they cannot remove all the tumor, but at least they will try to, by piecemeal, to remove as much as possible. So the standard of care is to use preoperative imaging, which is MRI in general, to guide this surgery. And then they use the surgery takes place under the microscope, and the surgeon can visualize the surgical field of view and has a correlation or knows where the tumor is located based on this preoperative MRI. The challenge is that when you open the scalp, there's no intracranial pressure, you have brain shifts. So the location of the tumor that they see in a preoperative MRI doesn't necessarily match what you see in what is in reality, the anatomical location of the seen directly during operation. So to correct for that, new image-guided surgery approaches, in this case, use a 5LA to induce PP9 fluorescence is currently adopted in multiple clinical centers and hospitals in order to be able to correct for this brain shift and better remove the tumor. The challenge is that this 5LA PP9 is limited to GBM or high-grade or glioblastoma multiforme, and is also a qualitative measurement. So this is not the ideal situation. So we thought, can we actually use now film to better characterize this fluorescence, the type of tissue, this resection margin or infiltrative agents. So again, you can see our film system here in the neurosurgery environment. This is the surgical microscope, and in the background, this neuronavigation system. Now, here it is the scanning of in a particular location in some cavity there. A microbiopsy is taken from that location that is used to actually validate our signal. And then you can use the mechanical pointer of the neuronavigation system to map that location on the preoperative MRI. So that allows us, this is it's much easier to correlate with the ground truth, because you actually can now take this microbiopsy from the same location where you did the measurement. So With that, I want to briefly discuss the questions and the problems that are currently in neurosurgery. So the new classification for brain tumors is not just low grade, high grade. So you cannot put all these tumors in the same bucket. And you have GBM or glioblastoma multiforme, which is the most invasive one. This is IDH wild type, so it's always a grade 4. And you have what was previously characterized as lower grades, oligodendroglioma and astrocytoma, which are IDH mutant. However, the oligo and astro are also different, and they also respond differently to chemotherapy or different treatments. So understanding exactly what type of tumors you have present is very important. And also this, what is called lower grades, in fact, they have different stages of grade 2, grade 3, astro is 2, 3, and 4. So now we start to look in more detail. Can we actually sense some of these changes? Keep in mind, I don't discuss this too much. Everything I'm talking about here is label-free, and the fluorescence in this case in the brain is dominated in a way we discriminate from NADH and FAD, which are metabolic cofactors. And NADH it's the reduced form of NADH fluoresces. And also when NADH is bounded to proteins, will have a longer lifetime than in a free form. So always you read out a combination of free bound NADH. So, and the IDH wild type and IDH mutant tumors also will influence the NADH pathway. So this is the relationship with the mutation. So the question that we are trying to answer is, can FLIM resolve oligo from astro? Can FLIM detect infiltrative agents at the resection margin and predict tumor cellularity? Because this is also important. The way how aggressive they are depends on the cellularity of the margins. Can FLIM overcome MRI-based neural navigation shortcoming by correcting in real time or providing information to correct in real time that brain shift? And more recently, we want to integrate actually this technique in a stereotactic biopsy, which is a completely different procedure. Some of these patients will have the stereotactic biopsy in order to evaluate what type of the nature of the tissue they would like to sample in a tumor. Right now, it's kind of done blindly. So with that, I'm quickly going to zoom in on some results from each of for these questions. We did see there are differences between oligo and astro. And this optical contrast is in these metabolic channels related to NADH and FAD. So this is important because the oligo and astro are biologically and behaviorally different, and insight of identification may lead to personalized actionable clinical treatment. The second question was, can we actually, what is our sensitivity in terms of cellularity of the resection margin? And we did notice that with increased cell density, you have a decrease in lifetime. Average lifetime is displayed here, and also a red shift. So in this preliminary study from, I think, was 20-something patients, we have, using a very simple model, we're able to have an AUC of over 76% in terms of delineating between low, absent and low, and moderate and high. We have an ongoing study. We have about 80 patients right now. We're looking at this, running new classifiers on this larger database. The third question was, can we overcome this shortcoming of MRI? And we are comparing now the results, since we have pathology results from the resection margin from that location, and we map it on MRI, how will MRI versus FLIM predict the nature of the tissue? And as you can see, we got very impressive results. We have a manuscript now in preparation for more than 25 patients. But you can see here, we're so impressed by the accuracy and specificity of FLIM in compare with both T1 and T2 FLAIR from MRI, which are over 90%. And then in terms of stereotactic biopsy, we practically adapted the stilled biopsy needle, which is used for this biopsy to integrate our fiber optic. And this is where you see this biopsy needle moving through the brain, including our fiber optic. What you see here is the average lifetime in one of the spectral channels. And as you can see how the lifetime changes as the needle progresses through the brain. So, and these are results from 3 patients. Again, we use a training data set from patients that underwent cancer resection to see if we can actually classify and identify the type of tissue that was biopsied. And here you see the accuracy for this type of 3 patients that we have the data from, including both astrocytoma, necrosis, and also GBM. So practically, we have now and answer some of these questions, still ongoing studies. But the idea is that using this FLIM and having knowledge about the nature of the tissue, we can modify the clinical and surgical strategy according to tumor type, in this case, oligo-astro. We can also, through the enable optimization of the extent of resection for improved survival rates, and also by able to correct and identify better the infiltrative agents at the time of the procedure. We can increase the confidence in preserving normal tissue. And by integrating this technique in a stereotactic biopsy, we hope to increase the diagnostic yield of the biopsy based on a biopsy sample. And quickly now, I know I don't have too much time left, but I want to show you that besides guidance of surgery, FLIM can be used in multiple other clinical scenarios. And probably the most challenging one is to use this technique in intravascular setting. So here we combine FLIM initially with intravascular ultrasound, and more recently with optical coherence tomography, and also with PS or polarization sensitive OCT. So the problem here, I will not have time to go in detail, but the idea is that some of these plaques are more likely, atherosclerotic plaques are more likely to rupture or to lead to clinical events. So there are 2 types of plaques which are currently critical. One are these vulnerable plaques based on thin cap fibrosarcoma, where we have a large lipid pool with thin fibrotic cap. And the second one are eroded plaques, which also can lead to critical events, which is no lipid pool. However, they can erode and also lead to formation of a blood clot. And the latter are more characteristic to women than men. So we want to see if we can actually use this technique to characterize the biochemical feature and couple them with morphological features from techniques which are currently used in clinical setting. Practically, as you can see here on the right, you can have different fluorophores in these arteries. Despite their overlapping spectra, they will have different lifetimes. And we use this contrast in order to look at the composition of these blood vessels, but also function, macrophages in particular, which lead to inflammation and degradation of the collagen cross-links and may lead to rupture. So as I said, we are starting to couple this technique with um, FLIM, in particular with ultrasound and OCT and PSOCT more recently. So this is a rotational FLIM system, is similar to what you saw previously, but now is the idea that this setup has to work through rotation and pullback. And you can imagine in a clinical scenario that you have blood, you can need to flash blood, you have heartbeat, so there are many other challenges. So we first integrated this with this OptiCross catheter from Boston Scientific, where both the ultrasound transducer is a single element transducer, looks at the same location, and you practically can get images like this, or you scan through, this is a scan through kind of a cylindrical structure, which is a human coronary vessel. And then you can augment this information on the segmental lumen from the ultrasound. So what this practically, these are fast image. You have now, again, multiple parameters. Each pixel will have 20,000 locations. At the time was about, this is scanned 20 millimeters artery segment or scanning in 5 seconds. So each pixel will have information in these 4 spectral channels, and that can be used to characterize the biochemical feature of each of these pixels. Of course, it's a tedious process to correlate this with histopathology, which we've done it, and we start also ask a variety of questions. One thing that I only want to emphasize here is that we're able, based on the information from fluorescence at 540 nanometer spectral channel, to correlate the just the lifetime, average lifetime, with the presence of macrophagiform cells, which is very important because that can lead to plug rupture. And not only with the presence, but also with the concentration in these macrophages. And we're able also to predict the presence of these areas or surfaces in the cohort or data set that we had at the time. So this was reported a couple of years back. So I'm going to skip this and just to show you that, again, FLIM now integrated with OCT. This is the most recent study. It's much easier to have all optical in this case. We're working with Brett Buma at MGH to adapt his PSOCT system to couple with our setup. And we developed this new catheter. And this is the first test of this technique in vivo in swine, in kind of beating heart. You can see here OCT images, the bioreferences and the polarization, and also the FLIM image at the bottom. And more recently, we'll start to look now at the how well we can characterize some of these features, combine the PSOCTs, those are complementary information in terms of detecting different composition of these blood vessels. So this is again a scan, and what you see here on the right is the correlation between depolarization, which is related to the presence of lipids, with the FLIM signal that also come from macrophages. Why is this important? Because in contrast to cancer, where you take the specimen out and you can do histopathology, in real case scenario, they will not take a coronary artery out. So you have to have a way to cross-correlate the information and, from different modalities in order to be confident of the composition. So with that, with these results that we're getting now from both swine, using the swine are healthy pig at this moment, and the data from these human coronary arteries, we are preparing an application, ID application, to do the first in vivo studies in humans using this approach. So practically, we want to have a paradigm where combining these two features, we can actually detect the two important type of plaques, the plaques with increased risk of rupture that are rich in lipids, and also the ones which have increased risk of erosion, which are characterized by increased this hydroxyurea rich matrix. And this is where FLIM appears to be sensitive to. So with that, I would like to say that I hope I convince you that FLIM can be integrated in a variety of clinical scenarios and can play a role in clinical decision making. I also want to say that FLIM is not alone, and multimodal systems or other technologies are important in order to look at complementary features. And I don't think we can, as people working in biophotonics and optics, can look at this in isolation. Other type of imaging, information from other type of imaging approaches, and also from physiology, patient history, genomics are important in order to for decision making. Practically, clinical decision making require a large amount of heterogeneous data that the physician will need to take into account, again, from genomics to laboratory values, to what we learned during procedures, to what the radiomics is telling us. And these are just some of the data that we need to take into account. And I like to show this slide where practically this interventional data science, if you look into the future, the interventional healthcare will evolve from artisanal craft based on individual experiences, preferences, and tradition of physicians into a discipline that relies on objective decision-making on the basis of large-scale data from heterogeneous sources. So I think we have to put this in a perspective that we are not the only entity in the universe. We need to take into account other features in order to improve clinical decision-making. And some of these approaches are actually pursued under this new P41 Center funded by NIBIB, National Center for Interventional Biophotonics Technologies, where we like to combine practically information from multiple optical modalities, but also to take into account holistically data from other sources in order to improve diagnosis and provide real-time actionable feedback. And with that, I would like to acknowledge many people who contributed to this work. And thank you very much again for your kind invitation and attention. Thank you.
For the flame-assisted surgery, a removal of cancer, does that make any difference for early stage cancer or late stage cancer?
So right now we are looking at characterizing both early stage, late stage in terms of long-term survival. We haven't run that type of study yet. That's a longer term. We just want to establish at this moment how well, and we can actually distinguish both early stage from a late stage, but it's always these tumors are not heterogeneous or are not homogeneous, are heterogeneous. And what you see at the core of the tumor will be very different than the age of the tumor. But in terms of how invasive they are, the metabolic activities and the signals, which I didn't show this data, but we do have evidence that, let's say, low-grade head and neck tumor or the cells from a low grade is different than a high grade. So it's not, we are looking not just of the cellularity, which is also play a role, but also whether that is an early stage of the tumor or late stage of the tumor. So some of these results are reported in one of our papers, but yes, we didn't look at the survival rate. I think the late stage is easy to distinguish, is what is actually happening. There is actually a margin that matters in terms of defining how much they will cut and how much tissue will preserve.
Eric Waite from Elephas. Great talk. I'm wondering how much pushback you got from the surgeons actually implementing this into something that's a little more risky right into the OR versus having something on a bench, let's say.
Well, the surgeons were pretty cooperative, so they you have to develop that relationships to convince that they can use these techniques and you don't interfere too much with their clinical management. I think this is very important. We had many failures. So every time when you go in, now we have a more robust, pathway to make things happen. So the surgeon, the surgical team is familiar with us. But at the very beginning, you have to practically learn how much you can push when you step back. And every time when you go in the operating room is different. You think that everything works, and on the bench top actually does work on the bench top, but when you go there, always you face some new situation. But we have so much experience now that we have a track record and a list of situations where things might fail, and we can fix it quickly. So, but relationship and creating a team. And it's just not with surgeons, but also pathologists is very important.
I'm just kind of curious. I know you've done work in both intrinsic and extrinsic imaging and surgery. What do you see the potential of, a combined palette of both intrinsic and extrinsic, and perhaps new intrinsic markers as well for surgery?
Intrinsic and
intrinsic and extrinsic, so taking advantage of the two together. So.
Yes, I don't show here for brain. We also look at the 5LA induced PP9 fluorescence. Given the fact that we can record simultaneously multiple spectral channels, we can actually correlate the signals from endogenous fluorescence with the signal from this molecular probe and see if they're 100% co-registered. And this is where, especially under the center, we have a couple of collaborative projects where the idea is to study the lifetime properties of different molecular probes that are currently approved by FDA or are on a pipeline, in order to see if, again, we can look simultaneously of both. The challenge is that is the light source in order to be able to measure the lifetime of these molecular probes, which are designed for excitation in near infrared. And what I show so far is excitation in UV at 355 nanometers. So it's not a matter of doing it, it's a matter of finding the laser that will allow to be practical enough. There are lasers out there, but you have to have lasers which are very compact that you can go on a cart, and again, to not interfere with the surgical environment in order to be adapted. But we are working in that direction as well to look at both simultaneously.